Hey, welcome everyone. I'm Paul Chapman. I'm the director for Restore Hope. And I'm glad that you've all been able to make time out of your day to have this training session on trauma. So many of the clients that we serve together in our communities are impacted by trauma. In fact, many of you may have had traumatic events in your life. You may be in counseling for trauma. And I'll tell you how I became aware of this is for many years I've been doing direct service with very smart people like you all. And I can't remember exactly who told me, but at about the same time, I was introduced by some folks that were looking at early childhood development and some of the problems that come from what we now know as ACEs, adverse childhood experiences. And they were actually showing the technology at the time now I'm starting to feel like an old guy, right? The technology at the time actually allowed us to see what all of us take for granted now, but they were showing some of the impact of trauma in the actual development, the physical development of our bodies, especially early on. And then there was some literature that was starting to roll out around reentry and folks who had been in and out of the prison system a lot. And so I know that you probably all know that, and I'm glad that you're here. We're going to have some time with Dr. Everett to ask questions. So I'd like to move on directly to her and her presentation. But if you would, I think we talked about this earlier, Doc, that if someone has, all these folks are on the front line, they've got real pressing needs, probably today, they were encountering clients that are impacted, they had very traumatic lives. Would it be okay that, as you're going along, if they had a question, if they could just ask that to you, and we'll moderate y'all. If you'll go ahead and type a question as we go through in the chat, we'll try to let Dr. Everett kind of stop along the way and try to answer your question. And you could come off mute at that point and kind of interact a little bit to make sure that we get you what you need. So Dr. Betty Everett is here with us. She's the director of the UAMS Center for Trauma Prevention. Doc, you've been at this for 40 years professionally. Dr. Everett, I have the pleasure of serving on a task force of the Arkansas Psychological Association, of which you chair, that chairperson of the board there. And so I've gotten to know Dr. Everett over the past several months, and we've got a real treat here and an expert in trauma. And so I'm excited to go through this. I'm going to try to share my screen here, y'all, and pull up her slide deck to go through. But just remember, if you've got questions for her, type it in the chat and we'll stop and do a little interaction. So Dr. Everett, if you'd like to go ahead and go, I will pull your slides up right here.
Okay, awesome. So I'd like to thank you all for being here today. I'm delighted to be here. Usually I can think fairly quickly on my feet. I'm not going to say I'll always be able to give you an answer that is maybe the best, but I think I can try to respond to what you need. I'm happy for you to all have a copy of the PowerPoint. There's some basic information in here that I think will be helpful. And I tend to be a pretty informal presenter, so I like the questions. If we, anyway, you can have the PowerPoint as a reference if we run out of time and don't make it all the way through the PowerPoint because of the questions. I want you to have the information. A little bit of more detailed history, I guess, is I am a native Arkansan. I grew up in Northeast Arkansas in a little town called Paragould, which you may or may not have heard of. I went to pharmacy school and practiced as a pharmacist for about 10 years before I went back to get my graduate degree in psychology. I went to the Oklahoma State University because at that point in time, the University of Arkansas would kind of flirt with their accreditation. They would have it and they wouldn't have it in the psychology program. So I picked Oklahoma State because I was very interested in child psychology, and they had a child specialty track. And this was back in the day when that was relatively unusual. So my first year on campus, um, I worked at Children's Hospital as a volunteer and did some biofeedback with children on an oncology unit. The second year, we start our more research component of our training, and I wanted to look at interpersonal problem solving in children who had undergone abuse. And so I called an agency in Oklahoma City to say, can I use some of your DHS referral kids to do some testing and get some information? And they said, sure, but you'll have to do a group for us. So I wound up doing a group with parents who had children who had had a sexual abuse history, and that's been my career ever since. So I'm happy to be here and be talking with you about trauma. We'll have a few different areas that we'll cover, and I wanted to start with trauma informed care because I think that's an important lens to look at the world through. And then I hope that's the right PowerPoint.
Is this the right one? Or do we need to pull up the next one?
I think it's the
Okay.
other PowerPoint. Oh, me too. So I wrote, prepared the PowerPoint and then had a good conversation with Paul and Rennie and went, oh, change tactic. So we have a PowerPoint that's significantly different than the first one. And I'm also happy for you to have both of them. Do you have it, Paul?
I'll find it right here.
Okay.
If you would go ahead and just kind of start.
Sure, yeah. So if we as healthcare providers, as we as people interacting with people in any agency, if we can look through a trauma-informed lens, it helps us understand things in a different way. So Oprah is quoted as this, and I actually think it was someone else who said it, and I keep meaning to track that down. It's asking the question instead of what's wrong with this person, what happened? And even as you say those words, you can feel the difference. So people who know me well know when I'm touched in my heart, I cry. And it passes pretty quickly. So I just keep on going. You think you have the right one?
Yeah, I think we've got it. This is the one.
Yeah, we do. Okay. All right. So go to my next slide and let me look at it then. There we go. That's it. All right. So Paul alluded to the ACEs, and this is a triangle that kind of comes out of the ACEs. And what we know about information from the ACEs, which is a research study done in Kaiser Permanente in California in the late 90s. And they were actually following women who had come in for obesity and weight loss treatment. And they kept finding that there were women who went through it, lost the weight, and then couldn't keep the weight off. And so they were trying to figure out what was going on. And so they developed this questionnaire that demonstrated that the adverse childhood experiences have significant impact on your physical health as well as mental health issues and social problems in adulthood. This study's kind of blown up and it's quoted everywhere all the time, and there have been a lot more publications related to it. In California, they developed a program that was community awareness and resiliency skills training. That next kind of blossomed in North Carolina, and I took that training many years back. And one of these days, we'll have something in Arkansas.
Questions?
That's just Any questions, anyone? Or those are just the questions for the ACEs, but if we move to the next slide, you can see it actually better.
There you go.
There we go. Yeah. So there were 10 questions, and they had to do with what happened in your childhood. So there are 5 personal events: emotional abuse, physical abuse, sexual abuse, emotional neglect, and physical neglect. And those 5 criteria all meet criteria for what we in the mental health field call uh, post-traumatic stress. The other questions are extremely stressful situations that don't necessarily make the full criteria, but you'll hear people talk about big T and little t. So sometimes that's a little bit helpful to make that distinction. So the 5 that are related to family issues are the absence of a parent through divorce, abandonment, or death. And I would argue that that can be a full-blown big T trauma. A mother or a stepfather who was treated violently, that also meets the criteria that would, if you were having PTSD symptoms, that would help you meet the criteria. A household member on drugs and alcohol, a household member who went to prison. Guess what? Y'all see those every day, don't you? Or a household member who was diagnosed with a mental illness. So what they found were these events in childhood really does make a difference. Next slide. So what does your score mean? It means that if you've been through prolonged and considerable stress during your childhood, it affects your health and well-being. It can interrupt brain development. There's a process called pruning where it kind of, the brain doesn't branch out as much as it might if you hadn't had the abuse experience. And there's changes in the nervous system, and in particular in the autonomic nervous system, as well as the frontal lobe. And we'll talk a little bit more about some of that later. But they can lead to serious difficulty. So high ACEs makes it more likely that you're going to have problems with alcohol and addiction. You're going to be a smoker. You're going to have an early initiation of sexual activity. If you're exposed to sexual behavior before your brain and body are developed enough to understand what's going on, it's really hard to then deal with that in adolescence and adulthood. You're more likely to have multiple sexual partners, more likely to have sexually transmitted diseases. You're more likely to have depression and suicide, liver disease, heart disease. There's just all kinds of physical health issues, autoimmune disorders. And I can't tell you how many of my complex PTSD, and I'll define that for you a little bit later, have really severe autoimmune problems. So these experiences in childhood can have a profound effect on you.
So Doc, I've got a question for you. That and so really, if I understand from your presentation, that the kind of the awareness of ACEs actually occurred when looking at physical health, not behavioral health.
Correct.
But what we've come to find is it impacts both.
Absolutely. Big time. Both. Yeah.
You know, it's the physical health that was surprising to me.
Mm-hmm.
Because you can understand maybe some really self-destructive behavior when
Sure.
you understand someone's story, but the interconnectedness of all of this is the surprising thing, I think. And I think the important thing for us to not only work on trying to get someone healthy, but to try to do everything we can to prevent this from occurring in the first place.
Yes, absolutely. Yeah. And treat as early as you possibly can. So the mortality rate of a person with a high ACE score, there are 10 questions, a 6 or higher, your life expectancy could be reduced by as much as 20 years because of these experiences. That's a pretty profound effect.
You know, so sorry, you probably want me in another room because we'll keep doing this, but I think that also is instructive for us as helpers in the community, that because it is, there are physical impacts, then we need to we need to take that into account and expectations of someone as their, the length of time to change.
Right.
It's just,
Right.
just, this goes so much further than just say no.
Absolutely. Definitely. Much,
Mm.
much further and deeper than that. Yes. And I'm not going to talk a lot about that today, but we see generational effects and generational transmission.
Mm.
You know, I think of the Bible quote of 7 generations.
Mm-hmm.
It takes that long to clean it out because you get epigenetic changes.
Mm.
So
Hey, for the dumb folks in the crowd that took,
means that your gene profile and how your genes are expressed can change based on your experience.
okay.
And that can be pulled forward genetically. So my having experienced abuse as a child might give me epigenetics that would impact my children.
Even though your behaviors and environment, it's just so again, we're talking about the whole person,
Mm-hmm.
not only the behavior, but also the physical impacts. So you're passing that on.
Yeah.
Mm.
Yeah. All right. Next slide. So, and this slide just kind of says what we were talking about, but I want you to note that it also adds health disease, diabetes, lung cancer. Again, I really want to stress autoimmune diseases because those are a lot of diseases that our medical field still don't know a lot about. Uh, I still see women in my office who come in with a diagnosis of fibromyalgia and their doctor like blows it off, which, is ridiculous because there are ways to work with it and treat it and help them. And what I can tell you is that effective treatment will have an impact on your mental health as well as your physical health. Okay. So next slide. So in addition to the ACEs study that emphasizes childhood experiences, um, you know, those development of mental health conditions in adulthood uh, show up from childhood to adulthood. Um, and so you see a lot of psychological concerns. People with trauma come into my office and they may come in with a diagnosis of depression or generalized anxiety or bipolar or some personality disorder. When, if you look at what's going on from a trauma informed lens, you know that the impact of that trauma that they experienced in childhood can really be expressed in a lot of different ways. So we see incredible comorbidity of substance use, of depression, of anxiety. It has a lot of effect on your psychological health as well. So next slide. So we can use this information to help us inform programs for prevention or early recovery, as well as innovations in our treatment. Um, so a lot of folks think PTSD is just talking about the military. So trauma changes the development and the ability of a child and a grown-up child to handle stress. There are real changes in the brain and the brain function. Again, these are reversible or seem to mostly be reversible, but they have a real significant impact. Okay, next slide. Any questions about the material that I've presented so far? And y'all have a good representative here with Paul asking the questions to help elaborate things. Do we have anything on the chat? Okay, so we're going to move on. So I'm preaching to the choir a little bit here, but incarcerated populations are more likely than the general population to have mental illness. For many women, experiences with poverty, mental health, substance abuse, and physical and emotional or sexual abuse contribute to their entry into the juvenile justice system. Data from 2006, I looked at some data from more recent 2011, 2020, somewhere to 60 to 80% of women entering jail and more than 50% of women entering prison have had one or more physical illness. There's a lot of disparity. African American are even more likely to have those kinds of problems. Hispanic also have a higher rate than the white population. Next slide.
Hey, Doc, there was a question.
Okay.
How are brain changes reversed? So how do you heal?
So part of healing is being able to find skills to cope with some of the triggers or some of the things that happen, being able to process the trauma. One of the things that happens is the connection between the frontal lobe and the back of the brain is not working in abuse. So the treatment will incorporate aspects of helping the brain heal. Is that a sufficient answer, or do you want me to keep yakking?
This is Chief Baker from Fort Smith. So
Okay.
he and his officers, are
Uh-huh.
of course coming into contact
Right.
with folks that have trauma all the time. And I would imagine
Mm-hmm.
don't react well to
Right.
authority
Yeah.
or comply with.
Right. Yeah. So we'll talk about this a little bit more. Maybe I'll reserve coming back to you after we've covered some of that material and explain it more, if that's all right. So let's go ahead and move on. Children with parents. Whoop, one too fast. Back up. Sorry. More than 5 million children in the United States have at least one parent in prison at one time or another. And this is about 3 times higher than earlier estimates that included only children with parents currently incarcerated. So we're seeing increases in the amount of children impacted by incarceration. And again, I know I'm preaching to the choir, but I know that that's important information for y'all. So we're next going to go into a little bit more detail about what is trauma-informed care. And I want to talk just a little bit about those things that you see on the screen. So co-regulation means that even when they're losing it, and I will put that in quotes, you keep calm. And if you keep calm, there's something in our system called mirror neurons that help us kind of connect with the person who's regulated, and that helps us regulate. Kind of like you might see a mom of a 2-year-old or a 3-year-old stay calm, and then the kid will get calmer. If mom escalates, the kid escalates. If mom can stay calm, the kid's more likely to get calm. Okay. There are brain function reasons for that. All right. Reflective function is just the importance of the connection and being able to validate their experience. Okay. Interactional awareness, again, is that a lot of, I believe, and our research kind of shows this, a lot of our efficacy of psychotherapy comes from the therapeutic relationship, which means it comes from connection. Okay. Do not underestimate that.
Okay, say that again.
A lot of the efficacy, why psychotherapy works, is because of the therapeutic relationship, which means the connection that you have with that person.
So really, I mean, a high level for me to understand this is this trauma occurs in relationship. I mean, it's harm done.
Yeah.
In relationship, but the way to heal is you've got to have a better relationship.
Right. The old words for that in psychotherapy, we used to talk about the corrective emotional experience, but I think it's even bigger than that. I think it's the corrective relationship.
Is that what 12 steps?
Kind of.
I mean, you've got AA, NA, and they've been around for a long time and helped a lot of folks.
And then there's a genuine connection with that. And one of the programs I'd hope to get going at the Med Center, and we haven't yet, and I'll find a way someday, is peer relations are incredibly important as well, which is a part of why AA and and all of those anonymous programs help.
We have a peer, a certified peer, actually here in the office with
Yeah,
us, and I don't want him to hear you say that.
Cool. Uh-huh.
We do have a good
That's
peer here.
right. So the next component there, let's see if I can read. Work through disruption and repair. So if you work with these folks a lot, something's going to happen, as it always happens in relationship. There's some sort of problem that has to be dealt with. If they can have the experience of you working through that problem in a successful way, it might be the first time they've experienced that in their life, but that's a real healing power to be able to know that life doesn't have to go perfectly in a relationship and it can still work. You can still be connected. Okay. And then, you know, focus on things that are good, the positive relational experiences. Okay. So in the trauma-informed world care, and SAMHSA and other kind of big national organizations really talk about this a lot, and the information that we're covering today really comes from their work. Traumatic events cause trauma. How the person experiences the event will determine whether it's a trauma or traumatic stress. That includes what they had around in their environment to support them or believe them, as well as the experience. And the effects of trauma include adverse physical, social, emotional, and spiritual consequences.
And so really what you're saying is that, you know, siblings could have the same experience and experience them, and could have the same event or endure the same event and have different
Correct.
impacts upon
Correct.
each of them, depending on where they were at the time that the event occurred.
Right. Yeah. And we know from way back when that one positive relationship for a child in childhood increases their resilience. It makes it more likely that they're going to go on and recover. So if you're that one positive experience for that child, it makes a difference.
I've had several clients over the years say that, you know, a coach played a big role in their life, you know, at that middle school, high school age.
Right. My second grade teacher, or my Sunday school teacher, or the neighbor down the street, or a friend's parent. You know,
I have a friend from California. It was a cop
mhm.
that got him out of trouble and then showed him the way, and he did everything he could to stiff arm him. And then, but then,
Yeah.
you know,
One person believing in you and supporting you is very powerful. Yeah. So I just thought we might look at a house that went through trauma.
fixer upper.
Yeah. A lot of work to do there, but it can be done. All right. Let's go on to the next slide. So this slide is in there because here's my classic example. If I'm a mom and a car has run over my child and my adrenaline spikes up enough that I lift the car up and get my child from out under the car, I'm probably not going to have PTSD because my nervous system, my fight, flight, freeze response gave me a successful outcome. Okay. But most of the folks that we see have not had successful outcomes. But if we help them learn to overcome stressors, then it begins to help change what goes on inside them. Okay. All right. So we have 4 other kind of things to consider in a trauma-informed care environment. Realizing is knowing that the incidence of trauma is a lot more than we give credence to. I see numbers ranging from 50 to 80% of the population have had a traumatic experience. Recognize is knowing that it has an impact, that it affects people's ability to regulate themselves and their emotion and how they interact. and that we want to respond in a way that is sensitive to their experience and what's going on with them. And by doing that, we can resist re-traumatization. You know, if I have a new patient that walks in the room and they're really nervous with me, it's important to give them time to get to know me. If I just barrel on through and not consider the fact that maybe an older female authority is scary as all get out to them because of their trauma experience, and I'm not doing them a service. Okay. So those are helpful guidelines as you think about trauma and trauma-informed care. Okay. So some of the key principles are safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, cultural, historical, and gender issues certainly play a big part. Let's talk just a minute about safety. So physical safety is really important, okay? Interpersonal interactions can also help promote a sense of safety. Physical safety is not the same as emotional safety, and they're both important. And I might think it's personally safe, but whether it's safe or not is defined by the person being served. Okay. So helping somebody feel safe who's had significant trauma in their lifetime is not necessarily an easy task because they've learned not to trust. They've learned not to feel safe. They need to know that you're not going to hurt them. And sometimes it takes them a while being in your presence to know that. Okay. Trustworthiness and transparency. So the goal is to build organizations and interactions with the people that you work with to build that trust and a culture of transparency, and to build and maintain trust with the consumers, the staff, and everyone in the organization. What's the question, Paul?
There was a comment from Nicole. She said that she's been a presenter before, but she learned that many women who have encountered sexual abuse have encountered it on more than one occasion. So it's multiple occurrences.
Absolutely. Absolutely. Yes. Yes. All right. Next slide. Peer support is a very important component of being trauma informed and working to help people heal from trauma. So a peer is someone who's gone through it. A peer support for a person is someone who's gone through it and kind of done their work enough to help you. And it can be a really important vehicle for self-trust and self-help. It's kind of like when I did a lot of work with parents as a younger psychologist, and I wasn't a parent, people would look at me and go, "What do you know about being a parent? You're not a parent."
I did 12 years in Catholic school, and in high school, Father Tribu taught sex ed.
Good. All right. Yeah.
We pointed that out to him that he might not be the best instructor.
So having gone through an experience similar to someone can be very powerful for them and give them a greater sense of hope. Okay. Collaboration and mutuality. Everyone's voice matters. Share the power in the decision making. I've got a treatment plan with someone. I want them to talk with me about it and know what we're working on, and it be their idea as much as possible, so that we're leveling the power between the clinical staff and the client. And it's empowering everyone from the support staff in the front to housekeeping to administration with information and training.
You know, Doc, a number of years ago, the Child Welfare DCFS, I don't know if any DCFS employees are on, but they have these team decision-making meetings, and where they'll pull the parents along with, you know, others in. And many of the parents have said that they're quite surprised that those folks there actually want to help them resolve the issue rather than, you know, drop the hammer on them.
Right. Right.
Um,
Yeah.
And so, anyway, that's
It's
kind of an approach
very
that
much.
they've taken. And
Yeah. 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 All right. So empowerment, voice, and choice is related to what we were just talking about. So, you know, they need to know that they have power and choice, and that their voice matters, um, because you're in it together. Cultural, historical, and gender issues. It's important to recognize and address that historical trauma has an impact. We're hearing much, much more about that in our world and in the media these days, partly from seeing how minority populations working as workers in COVID out being exposed were, you know, unbelievably impacted and impacted more. We want to honor cultural values and practices. Um, you know, how I think about it as a Northeast Arkansas person might not be how someone from Southwest Arkansas thinks about it. So, and we want to be responsive to gender issues for the person. It's a lot of women with a significant sexual abuse history. Often you can see them go into prostitution, you can go into same sex relationships, which is part of, you know, the confusion for them. Uh, and so it can complicate an already complicated issue. Um, okay, next slide. So the underlying question is what happened? Symptoms are adaptation to traumatic events. Healing happens in relationship.
you know, there was a very popular TED Talk. It's probably 10 years old now, but the individual all of his family except him had experienced substance abuse disorder. And so the conclusion of this TED Talk was that the opposite of addiction is not sobriety. The opposite of addiction is connection.
Connection. Mm-hmm. Yeah. Yeah. Like that. All right. We're going to shift gear in just a little bit and go on to the next slide. Um, I just want to give you kind of some of the language that you might hear in a mental health clinic. Acute stress reaction is something that's pretty close in time to when the stress happened. An adjustment disorder means you've got kind of a mild traumatic response. You're just adjusting to something. And acute traumatic stress occurs within the first month, and it actually needs to be treated a little bit differently than a post-traumatic stress disorder, which is, you know, at least a month out and could be years out. Post-traumatic stress disorder complex is just now entering the field of medical diagnosis. At an international level, it's been recognized longer, and it's finally making it to the United States.
What's the difference?
You'll notice the parentheses, it's more chronic and it's developmental. The complex disorders often are folks who've had childhood experiences and multiple childhood experiences and chaotic families and a lot of disruption in attachment. So these folks have a series of symptoms that are in addition to the complex PTSD diagnosis. So they have problems with interpersonal relationships. They have problems with emotions and emotional regulations. They have problems with getting triggered and self regulation. They have difficulty with their view of themselves. Okay, so it's much deeper and more complicated, and takes a longer to treat, and the relationship becomes even more critical.
So let's say, because I'm used to PTSD really occurring like, you know, when vets come back from a war zone, where everything's amped up and and they may have experienced loss of, and but that's different than the complex, which may have occurred at real developmental
Right.
time.
And it usually has an interpersonal violence component to it. So you might have somebody come back from the war with war-related PTSD, which would be a more acute event or a more recent event. But underneath that, they may have had a childhood of abuse and neglect. And so I tend to diagnose both.
Hmm.
You know, they're giving me real significant recent trauma that needs to be dealt with, but there's also these underlying deeper
Hmm.
developmental issues. And so the brain changes and the body changes that we talk about really are more from a complex picture than I had a car wreck and I'm, you know, wigging out about it.
Mm-hmm.
Yeah. So I'm happy the world is looking at that and working on that and acknowledging it more.
You know, even so many of our clients are without means. They're poor. They don't have a lot of means, but I've met some people who are quite successfully, they made a lot of money.
Yeah.
Yet when you get to know them, but they'll behave in a way where relationships aren't easy for them. And I've gotten to know some of their backstories, and like one individual that I'm thinking of grew up hungry to the point where there wasn't real safety.
Yeah.
There was it's he and his mom, and so he's still, can pursuing the money, although he's got all that he could ever spend.
Right.
But he's still trying to make sure that it never goes back.
Right.
He's running away from
I'm not ever
his childhood. I'm never.
Right.
And so there's never enough, but
Right.
also the emptiness of realizing that that's not fixing what's wrong.
Right. Yeah. A traumatic stress disorder, not otherwise specified, means you meet some of the criteria, not all of the criteria for post-traumatic stress disorder. With these, you can see a lot of dissociation. You can also see somatization. And I believe that's because, and you can find much more literature about this out there now, that the body can hold these memories. And I think that's connected to the physical health issues and autoimmune issues. But trauma affects your body. Okay. Body. Yeah, it shows up in the body. So, for instance, when I worked at Children's Hospital many, many years ago, we had an inpatient psychiatric unit. And the folks that were in neurology at that point in time found that when they had a seizure disorder that was not following the usual pattern of organic seizure disorders, they found a sexual abuse history. Yeah. So some people call that a somatization disorder, and in some ways that's appropriate, but it's back to, if I'm trauma informed, I might understand that a lot differently than think, oh, they're just crazy.
Mm-hmm.
Yeah. Yeah. All right. So this is some of the symptoms that you see. It's not a very good slide with post-traumatic stress disorder and complex post-traumatic, and we covered some of that. So the key components that you see for PTSD are that heightened sense of arousal, always kind of looking around for the threat, what's going to happen, that, and then avoiding anything that triggers or help that you remember, so you kind of narrow your world, and the re-experiencing, like the flashbacks, the nightmares. Okay, those are kind of core components of PTSD. So with complex PTSD, you have those plus the difficulty with emotion or affect, difficulty with how they feel about themselves, and interpersonal. Now I'm going to show you some side that we're not going to necessarily talk about in detail, but I wanted you to kind of know that PTSD it's important to look at it in terms of its diagnosis. It affects the hormonal system. It affects your genetics. It affects your immune system. And there are a lot of ways that we're beginning to see that show up in imaging studies and other things. So again, core features of post-traumatic stress disorder are the avoidance, which certainly makes a lot of sense. If there's a tiger in the hallway, I'm not going to walk around it. Re-experiencing the hyperarousal, changes in cognition of yourself, not just with complex, but you also see that with more, quote, simple PTSD. It changes how you feel and think about yourself, others, and the world. It impacts how you view responsibility, your sense of safety, how you deal with power and control issues. It affects your self-esteem, and it affects your ability for intimacy. Okay. So that's a big impact. Now, I want to go into just a little bit of anatomy because I think it can help you in some ways, help you know how to deal with it yourself or to help others. So our autonomic nervous system is an automatic nervous system. It's not our thinking nervous system. It's more the primitive part of our brain. So if you make a fist with your hand, and this part of your hand that's down kind of around the wrist, that's the autonomic nervous system. It's the most primitive part of the brain that developed first, okay? And there are two components to it. One is the sympathetic nervous system, and the other is the parasympathetic nervous system. And they work together, okay? So the sympathetic nervous system, when you get under a traumatic stress or a high stress, you go to hyperarousal, and that's what's responsible for the fight flight. When the sympathetic nervous system says, whoop, let me get activated here. Okay, I'm going to run away, I'm going to fight. If you can't fight and you can't run away and you're still in the middle of it, then the nervous system says, well, we got to do something here. And so a part of the parasympathetic nervous system, which is usually about peace and calm and connection and regulating, and it's a more primitive, dorsal just means it's toward your feet. Okay, so it's an older part of that nervous system says, we're freezing, okay? And that can go to the point of like what you see with an opossum that's playing dead, okay? You really kind of check out, and that you can also then get the dissociation that can come with that. This is too much to deal with. So my mind, my spirit is going somewhere else. Okay. And it's survival. And it's not consciously regulated. Your body does it. Okay. If you're in a calm state, you're either kind of operating out of the sympathetic and the normal range or the parasympathetic and the normal range. And we're learning more about that normal range, parasympathetic, and people can now refer to that as the connect circuit. And it regulates your heart and your lungs and your face, those areas of the body that help us socially connect and interact. Okay. And if that's online, you're doing good. If you're in a traumatic stress response, you're not able to connect. But if there are some things you can do to help get that person to connect to you, it's going to help regulate their nervous system. In the same way that if you stay calm when the person is not calm, it helps regulate them. Okay. So then we start talking about the window of tolerance and co-regulation. So if you can go to the next slide.
Betty, we've got a question.
Yeah.
Can you explain? So we have a lot of folks that are working in the child welfare area. Can you explain what's going on kind of with a child who's removed? So a child's placed into foster care. Many, if not most, of the reasons why a child is taken into foster care in Arkansas are really not due to abuse. They're due to neglect, areas. And so can you kind of run through with the trauma lens, what's going on in the kid's head?
Yeah, so it could go one of two different ways. If you've had a whole lot of neglect, you're much more likely to kind of check out. You're kind of not in the full freeze response, but it's kind of like, I'm just not going to interact with the world. But if something triggers an immediate danger, then they might pop out of that really fast and go to a fight flight response, which is when they're acting out or they're angry or they're hurting themselves or somebody else. So if we can flip to the next slide, it gives you a little bit of a visual of that. So if you can kind of look at that white space in the middle, that's the window of tolerance. That's when I'm calm, I'm regulated, I can learn, I can think, my brain's working, okay? So remember that hand I showed you? When you get triggered, and we'll talk about those a little bit more in a minute too, it's like the thinking brain goes offline. So usually there's a connection between the primitive brain, the feeling brain, and the thinking brain. And with trauma, the thinking brain just kind of goes offline. And that autonomic brain, that fight, flight, freeze response is in charge. And you can't think and you're just reacting. Okay. And it's really difficult to regulate. Does that make sense? Does that answer the question?
Yeah, right. So one of the things that we found is we've got to work to get our clients. It's almost a triage. There's so much going on. Let's get to safety. Let's get to where you can kind of calm down.
Right.
And then we can work on maybe some training to get you to career, because so much of the training now is abstract. They're thoughts rather than real concrete.
Yeah.
So abstract thought.
You got to get them regulated first.
Mm-hmm.
You got to get them calm. You got to get them safe. You got to get that thinking brain back online. Okay.
Even in our manufacturing now, it's so much of it's working with robots.
Mm-hmm.
So the robot will punch the doohickey, but you've got to make sure that the robot's punching them in the right way and at the right size. And all that's abstract thought.
Right. Yes, absolutely. Yeah. So trauma affects your ability to think and use the rational brain. Next slide. All right. So we've already talked about that, so we don't have to go on with that. Okay.
I like that you smart people called it the reptilian part of the brain.
Yeah. So triggers are things that cause the alarm system to go off. And I don't want you, we're not going to do a neuroanatomy here, but there's something in the brain that's called the amygdala, and it is like a smoke detector. And so it's constantly scanning the environment to say safe, not safe, safe, not safe. And for folks with significant traumatic history, their brain has a faster trigger to not safe. They're primed to react more, faster, to not see it as safe. And it's harder for it to settle down. Okay. When the amygdala hits, oh, not safe, then that autonomic nervous system kicks in to do the fight, flight, freeze response. Okay. And the pathway from the amygdala to the frontal lobe can't get accessed. Okay. Next slide. That's hyperarousal.
I think I passed that guy on the way here today.
Next slide. All right. It's hyperarousal is a state of increased physiological and psychological tension that presents itself as symptoms. Man, that's wordy crap, and it sounds like some PhD wrote that. That has the effect of putting you in a chronic state of fight or flight. When this occurs, the breath becomes shallow, the heartbeat becomes rapid, you're on hyper alert, your muscles are tense. You no longer remain the longer you remain in this state, the more drained you become physically, psychologically, and emotionally. Okay? And people with significant PTSD live there. The fight, a lot, a lot. This fight flight response was once necessary when our ancestors were consistently faced with physical threats, and we're in a different world now. And for the trauma victim, it's as if they were back in the trauma and the trauma happening right now, because your sense of time and space comes from the frontal lobe, not from that part of the brain. So when someone is re-experiencing, they are lost back in time. Okay. Next slide. All right. It's unconscious. It's not automatic. A lot of people have a lot of guilt and shame around this response, and it just happens. It's the brain doing what the brain does. Okay. So let's go on to the next slide, which is hypoarousal. Whoops. So these are just some things that can really help. Is breathing, slowing the breathing down, deepening the breathing, and connection can really help a person get out of the hypoarousal. Now let's go back to my cute little hypoarousal.
It looks like a picture from my college days.
It might be you.
I think that guy was my fraternity.
All right, next slide. So the freeze response and hypoarousal are a lot more common than we think. People are really kind of checked out sometimes. Learned helplessness theory of depression really may relate back more to trauma history. Okay. So if we can get to know their history and get to know them, you can begin to notice when they're checking out better than when you first kind of interact with someone. So hypoarousal can look like depression. They may have little emotional response, low energy, flat affect, shoulders stoop, little enthusiasm or motivation. Can be an almost perpetual state for those who've developed avoidant attachments as adult, which happens with neglect kids who are neglected. They have they either have a disorganized attachment or they have an avoidant attachment. If they're lucky and they got a little more, they may have an anxious attachment, but they've not had a parent that they could attach to safely. And so they're like, they're looking for it. They're trying to find it. They're trying to find that empty space, like Paul was talking about with his friend and the food. Helping them kind of shift their postures or walking around instead of sitting can help them get out of that state. If they can feel safe with you, that can help them get out of it as well. It's a trauma response, okay? And so acknowledging that and helping them know that can be very helpful. Next slide. So the freeze response, it's really much more evident when they go into the freeze, and sometimes that can really lead to dissociation. And with dissociation, they may or may not be able to interact with you. They may kind of suddenly kind of interact a little differently, and that can be confusing for you or them. Okay, but they're stuck and they don't know how to get out of it. So helping them orient to the present, look around, what do you see now? Get more centered right here, right now can really help them pull out of that, especially if they're in the presence of someone that they trust and can connect with. All right. So part of the work of therapy is to help figure out what's triggered the freeze and helping them learn to deal with it and get oriented to the present. So I want to go back to whoever was the police person from Fort Smith who asked the question and see if there's anything else he'd like to ask me about. Haven't heard that.
Chief Baker, if you're still on, do you have any other questions around especially around, getting better? I think he was really looking at, so if the trauma actually impacts us physiologically, then how in the world do we ever get better?
Mm-hmm.
If it's not just a decision to change behavior, although that comes
Right.
along,
Right.
but you're fighting against.
Yeah. So what I would just try to do is learn the skills myself for regulating, like the breath, like the orienting to the present, like moving around, like
What is orienting to the present? So
what do I see? What do I hear? What do I smell? What do I taste right here, right now in this room? You know, can you see my face? Can you look? Eye contact can sometimes be hard, so I don't always do that one. But if you can get someone who can look you in the eye, they're probably going to orient a lot better. Their nervous system is not in present time. So one of the things that can be very helpful for someone working with them when they're in a dysregulated state is to help them use some skills that they may not have in their repertoire to get regulated, because then they're going to be able to think and be more logical with you. If they're in something's going on that they're being arrested, they're probably going to get pretty triggered into a hyperarousal. And so, things that help them breathe and be present, and know that your intention is not to hurt them, not that you have necessarily done anything that would give them that idea, but that's where their brain has gone, will help them get more oriented. And part of therapy is teaching them the skills to do that so that they can begin to recognize, oh, I'm in hyperarousal right now, and let me breathe and do what I know to do to take care of me. Okay. All right, next slide. We're froze.
Oh, I'm sorry. I think Danny.
Oh, we have a question?
Well, Danny had moved his video.
All right. So this is an Everett model. So bear with me on this. But if you think of the environment as being a trauma-informed care environment, that I'm aware of the possibilities of trauma and how that affects people and how they interact, then within that, there are several factors that in a therapeutic relationship you want to consider. On the one side, you see the client factors, and on the other side, you see the clinician factors. Okay. So what's going on with the patient or the client and what they want and what they need and how they're functioning has a tremendous impact on what's going to happen. Okay. What you know as a person, what I know as a clinician, my judgment, my knowledge has an impact on what's going to happen with them. Okay. Also, we have a lot of research and evidence-based practices that we know work, but those have to be adapted and used through that particular person and that particular clinician for it to be effective. I can't pull out a module of evidence-based treatment and not adapt it and be as effective. Okay. The other thing that's a really important factor is the environment. And I think you all know how critically important the environment can be, because I can be going along and having, pretty good success working with someone, and then somebody dies and it's all different, or a tornado goes through and it's all different. So the external environment has a big effect on how people are doing and how they're coping and how they can work with you in treatment or in relationship. Okay. And then within that, you'll see a second circle. And for me, that is the therapeutic environment. It's the multidisciplinary team. It's the community for y'all that you have built. It's the DHS worker. It's the policeman. It's the, um, justice system, parole folks. It's the family. It's you. There's a team that really helps what's going on. And then the heart of the matter is that relationship, that therapeutic relationship, that they know that you're there, that you care about them, that you're trustworthy, and that they're going to learn new and different ways of being with folks in that relationship. And then I think that helps people get to that core sense of self, that essence of who they are. And so I think those are all pieces of what helps people kind of be who they really are and have the life that they want. Okay. So next slide. And we're not going to go through all of this, but I wanted y'all to have this as a reference. This is a list of the evidence-based treatments that we know are really effective for the treatment of PTSD and a little bit of complex PTSD, starting with trauma-focused CBT in children, the child-parent psychotherapy, which can start at infancy, the seeking safety, which is used with adolescents and adults and folks with trauma and substance use histories. Prolonged exposure is a method of treatment for trauma. Cognitive processing therapy is one of the evidence-based treatment programs, and EMDR, the eye movement desensitization. So those are kind of the core pieces of evidence-based practice that we have a lot of information on that says administered right in a good relationship, they work.
Okay, so I have heard this, but it sounds a lot like snake oil to me. But EMDR, the
I
flashing
love
light.
EMDR.
I know I've heard so many smart people, but it really does. I think you're like you've slaughtered a live chicken and you're about to sprinkle blood on me or something.
Okay,
And so what's the magic behind the?
Talk about this a minute then. So number one, it's a therapeutic relationship. Okay. Number two.
Not that I'm a skeptic or anything, but
anything, yeah.
I'm
So
kind of, hey,
yeah.
so let me ask this.
You want me to do a treatment on you right now?
No, I do not consent to that, Doc. Keep your sacrificial knife and your bag of bones over there. Hey, no, seriously, on EMDR,
Yeah.
I mean, this is a recognized treatment. Insurance will pay?
Yeah, absolutely.
Okay, so here's, okay, so
I'm going to explain it to you.
As a skeptic,
Yes.
I would say that one is, I mean, folks like you that have been in this field a while, have told me that it works.
Yeah.
Because immediately the first time I heard of it, they said, hey, we're getting really good results. And I'm like, that is snake oil. I mean, placebo effect, if ever. But here's how I know, right? Not only because the money people, the insurance people, they're paying for it.
Right.
And they don't want to pay for anything.
Right. So I think there are a lot of processes that are involved in EMDR that make it important for me. So one of the distinctions I want to talk about just a moment is top down versus bottom up processing. And a lot of the cognitive therapies are, let's think about this.
Uh-huh.
Let's think about how you're thinking, and let's see if we can change how you're thinking.
It's CBT kind of stuff.
Yeah.
I mean, which is an evidence-based model for.
And so that's what a lot of that is.
Okay.
But if my brain's going offline, that's not going to work.
Yeah, if you can't put logical or rational thoughts together, it's hard to
do that.
Uh-huh.
Yeah. So there's a place for it, and it's really important, and I use it, and I will continue to use it. But if I'm holding the trauma in my body, I need some process that works more from the bottom up. Okay. So
I'm with you, Doc.
all right.
I'm just smiling while you're saying it.
I'm sure you are. So we know that at night we have REM sleep, which is a rapid eye movement. And the bilateral movement that is associated with EMDR may do something in the brain, sort of like dream sleep does for us at night. It helps us process things that have been overwhelming. So if something happened to me and it's beyond the capacity of my brain to deal with, it doesn't get plugged into the brain in the normal kind of ways. And so you keep re-experiencing it because your brain,
You're stuck.
you're stuck. And so something about the bilateral movement helps you get unstuck and helps you put it in the perspective. So when I'm doing an EMDR session, I'm wanting someone, if they can, to give me an image of what happened. I want them to tell me the emotion that's associated with it and how intense is that emotion. If 10 is the most, where are you? And often they start at a 10. I want them to tell me what they notice in their body. A lot of people with significant PTSD have spent a long time avoiding their body. They don't want to know what they feel in their body. And so it can take some time for them to be able to tell you. When I remember what happened to me when I was 5 years old, my stomach is like in knots. Okay.
I view it almost, you're standing on the manhole, you know, the monster's trying to get out, but you're afraid that if you ever let it out, that that's it.
And then I want to know what they're thinking. So they might be saying, I'm worthless. You know, I don't have any meaning. I don't need to be here. Okay. So, and then I want to help steer them to, well, if you could believe, what would you want to believe instead of I'm worthless? God don't make no junk, or I'm worthy, or, you know. And so how much do you believe that positive belief? Zippo to begin with. And then they hold all of that in mind, and you start doing this, or you start doing this. And one of the things that helps me with is I know they haven't gone out in space, because if they're still able to move their eyes with me, I know they're present. So I know they're in that window of tolerance, at least enough to be able to be in the past and be in the present. So that's one of the ways I explain trauma work too. It's like, you gotta be dually aware. What happened to you in the past has to be alive enough that you feel it and you're experiencing it, but you got to keep a foot in the room with me too, because we're not going to go back and just re-experience it. That's not going to help you. The EMDR seems to help them stay more in the room. It seems to help them be able to feel really intense emotion and come back down. And what I often see is the image might shift. Somebody might say, Doc, when we started, it felt like I was 4 years old again and it was happening. And right now it's like I'm kind of standing back and looking at it, like I'm observing it. My gut's not on fire anymore, you know, or my level of emotional distress is down. So for me, the proof is in the pudding.
Yeah.
And partly it's because I've always been someone who, I don't care if it makes a lot of sense or if it sounds like snake oil. If it works, for it.
Well, when I first heard of it, I didn't have a good picture of what kind of put on it. But if you remember the guy from January 6th that wore the bison helmet, and he had an interview where before he would engage evil spirits, he'd beat drums and dance around a little bit. That's kind of what I was thinking was in the same level of
the drum is a bilateral movement.
I'm going to send you a video. Maybe to those that stick with us to the end, I'll share that video.
See what the questions are.
So Chief Baker did say, and he pointed out a really good question here, is that so many officers, they're day in, day out. And I would imagine, I know that in the past couple of years, being a police officer, it was hard and it's gotten worse. And I can't imagine the difficulty now in trying to even recruit officers, new officers onto the force. But officers can experience trauma on the job.
Absolutely.
And so, and he was pointing out really where his question was I think he's trying to connect this now to not only the clients that they run into, just the citizens that they're encountering, but also the officers, the need for them to be able to
Absolutely.
deal
Absolutely.
in a good way. So how do you overcome? Because it seems to me that in the military and in law enforcement, and Chief, if you're still on, I would imagine that there's a bit of a resistance to seeking treatment for a couple of things. One of them is just kind of the, I'm tougher than that. I'm not going to admit weakness. The other would be, I think, maybe professionally as being seen as it may be impacting your career. I know that,
Yeah.
I know Chief Baker, and that wouldn't be
Right.
what he would want in his, but I would imagine that in those environments,
Yeah.
that those two things are true.
Yeah.
Is it may be seen as weakness, and number two is it may impact my career.
Yeah. Is that him?
Yep.
Are you asking me to jump in? I don't
Yes,
want
sir.
to step on the.
Yes, sir. Is that kind of to your question?
Absolutely. Absolutely. I mean, I've got, how my mind works. I've got several connections going at once. I'm also thinking, how we might work with our homeless population with some of this stuff. But, I mean, officers' mental health and well-being has always been an issue, but you're right. There's always been a stigma attached to getting help or acknowledging that, that an officer has a problem. And these folks, I mean, the kind of things you're talking about that generate PTSD, I mean, they're exposed to it on almost a daily basis. A child dying, a suicide, a death, a horrendous car accident scene. I mean, these are all things that, they compound and they pile up. And I mean, we are really trying to get officers, we're trying to get them to the help that they need.
Right.
And get them in front of counselors and that sort of thing every time they're exposed to these things, not just when they say, oh, I'm having a problem, or it's manifesting itself in performance issues on the job or excessive uses of force and that sort of thing. But, we also had legislation that came out this last session where, I don't think it went nearly as far as it needs to, but police officers in Arkansas are now mandated to obtain mental health treatment and counseling after a critical incident. But
Right.
most people think of a critical incident as an officer involved shooting and leave it at that. Far more than that. But yeah, that's where my thought process was going, and what you had to say just really kind of, I mean, it helped to solidify what I'm already kind of thinking, that we got to get that treatment. We got to get it quickly, and it's got to be the right treatment, because that healing process can take place.
Absolutely.
They aren't damaged goods that can't do their job anymore. We can provide them with help and treatment.
Right. Absolutely.
Like with all things, I think making sure that the counselor client, it's got to be a good connection. And finding counselors that can understand law enforcement and the pressures and then connect with that, just like with military, is going to be important, because you're not going to, frankly, you're not going to seek treatment.
Right.
You're just going to, let's check the boxes. Let me get back on on the job. And
so I think I have, this is an EMDR commercial, among other things, but the International Association, EMDRIA, EMDRIA, has always had a humanitarian component. They've gone to war-ravaged countries, natural disaster areas, and they do that freely. And in Arkansas, there are central and in the four corners of the state, an EMDR trauma recovery network, TRN, and they're folks trained in trauma. They're folks trained in recent events trauma, which again takes a different approach than if it was a long time ago. and they will offer those services for free. So I can give you the contact for the person here in Central Arkansas that does that, and she would be able to give you the contacts for all
Okay.
regional people.
I'll get those.
Yeah.
We'll get those out
Yeah.
to the
Yeah,
folks along with your slides, if that's okay.
sure, absolutely.
We had one additional question. Karen is asking, could EMDR be used on small children? She has a child of a client who's been reunified, but is not responding to treatment right
Okay.
now. Mom's at her wit's end.
Yeah. Yes, it has shown to be very effective in children. I can't give you the bottom age range. But how old is this?
Hey, Karen, how old is the child? 6.
EMDR can be used in a 6-year-old. Absolutely.
So you might suggest that, Karen, to
Yeah.
mom.
And in children, you don't do as many of the bilateral because they don't have like a lifetime of storing it in, and their attention span is a little different. So it's adapted as a play kind of thing sometimes with kids, but it's very effective in children also. The EMDR International, if you Google that as a consumer, you can find a certified EMDR provider in your area. There are a lot of folks in Arkansas now who are trained, who are not necessarily certified, but really good providers. So if you have trouble, let Rennie or Paul know, or email me directly at the Med Center, and I'll see what I can do to help you find if you don't find anybody.
Jamie points out that there are free EMDR videos available on YouTube for our clients who can access EMDR treatment and trauma therapy. Another resource I've given to a lot of our female clients is a website called Bloom for Women.
Okay.
Has dozens of courses with videos to help women move through trauma when they don't have the ability to go to trauma-specific therapy.
Yeah. There's some really excellent YouTube videos out there on that snake oil EMDR.
I am going to share a 10-second video with you. I believe you because you're smart and you're here. I still see the guy with the bison helmet
know,
on telling
I
me
know,
that
I
it
know.
happens in the spiritual
Well, I'll
realm.
tell you, I've been doing EMDR for over 30 years now. And when I first started doing EMDR as a practicing psychologist, I caught a lot of flack for it. I mean, a lot of flack for it. And I might even hide the fact that I did it at times. All right. Let's go to the next slide. And I'm not going to go into a lot of detail in this area because I want to pop on to something else. But this is looking at if you're needing to make a crisis prevention plan and to deal with something going on in the present. So you want to identify triggers. Next page. These are some of the things that might be triggers to people and cause them to go into a crisis. Okay. Some more things that might be identified as triggers for people. Go ahead. Strategies are things that for that particular individual are helpful for them. Prayer, meditation, time away, going for a walk, just some simple things. Go ahead. And some more strategies that might be helpful for people. Okay, next slide. So I want to talk about psychological first aid. And psychological first aid is used in the moment of a trauma. It's like it's just happened. So it's for recent events. And for some of the folks, and probably a fair number of the folks that you talk about, it's often a current crisis situation that gets them to you to begin with. Okay. Next slide. All right. Next slide. So an initial disaster response intervention with the goal to promote safety, stabilize survivors of disasters, and connect individuals to help and resources. I believe that might be your mission statement. PFA is delivered to affected individuals by mental health professionals and other first responders. You don't necessarily, you can be a helper, you don't have to be a certified mental health person. And its purpose is to assess the immediate concerns and needs of an individual in the aftermath of a disaster and not to provide on-site therapy. Okay. You want to provide help, support, advise, guide, assist, and give them information. Okay. So, man, okay. So this process was developed jointly by the National Child Traumatic Stress Network, which can also get you some really nice resources, and mental health providers. It's an evidence-informed modular approach for assisting people in the immediate aftermath of disaster or distress. It's for use by first responders, incident command systems, primary and emergency healthcare providers, school crisis response teams, faith-based organizations. A lot of folks have adapted this model and used it. There's just some resources for you. There's a mobile app you can get, and there's a download of handout for survivors. Okay. So action 1 is contact and engagement. You want to be aware of the cultural and developmental issues of the population or the person that you're working with. You want to reach out. You want to work as a team. You want to plan for ongoing needs, including ongoing support and referrals. Okay. Action 2 is to ensure safety. Watch for high risk or the dysregulated behavior that we've talked about, because people are going to be out of the zone. Okay. And you want to support those with overwhelming grief. Okay. The third core action is stabilization. You want to identify those who seem to be more vulnerable. You want to, if you can, get some history of prior mental health or substance use and what coping strategies they might have, and help them kind of connect with some of that. And differentiate between physical and emotional distress. And often they're going to have both. Okay. Next slide. Information gathering. Find out everything you can about what happened and develop a referral system. Information or education or knowledge about risk factors and signs can be very helpful for them. And you want to proactively screen and assess all that's involved. Screen in terms of what did they see, what's going on, and more than what happened is how are they doing? You know, how are they coping? What are they needing? Okay. The next core action is practical assistance. Don't underestimate the importance of this. It's a very protective factor and enhances recovery. Identify the needs and barriers to obtaining resources. Link to support staff or agencies and contacts that can help provide these services and help coordinate the needs.
You know, this is where I see the Alliance, the folks that are on the Zoom right now. This is a real strong suit of them because they're able to, whoever's taking kind of the leading role in relationship with the client is now connecting them. I mean, and it's, you know, they're taking care of it, immediate needs immediately.
So incredibly important. So incredibly important.
And that helps build the trust, I think, between the case
Absolutely.
manager and the client,
Mhm.
so that when they go on to move to work on some of these
Right.
difficult
Right.
things.
Yeah. Yeah. Next slide. Action 6 is information. Let me go back to action 6, connection with social support. Again, we've talked about how social support helps regulate our nervous system. It can help establish connection and develop ways to increase interaction. You know, give them information on health and mental health and related topics pertinent to their crisis, publicize upcoming supported community events, help them reconnect with friends, family, other support, and integrate new people. So knowing that you're not alone and dealing with this alone can be incredibly helpful. And I think you guys know that. I just want to reinforce that what you're doing is important. And then information on coping, provide information about common reactions, address safety concerns, and discuss available resources. And be prepared to deal with their stress. The more you learn to use your skills and regulate yourself, the more you're going to be able to be present for them in a way that is helpful for them. And there's no one way to recover. People have their own ways of dealing and doing that it's important to honor. Okay. Is that a question coming in? Okay. Core action six is linked with collaborative services. Provide information on available services. Um, Date the referral list. There's always at least one typo I don't catch. Date the referral list to include trauma and loss informed services and facilitate access to those services. So back to the chief's comments, self-care is really important, and you can get secondary stress, and some common stress reactions are increase or decrease in activity, difficulty sleeping, increased use of substances, feeling disconnected or numbing out, being more irritable or angry or frustrated, or feeling helpless or hopeless. When you work with these folks a lot, it's really not unusual to kind of get to a point of feeling helpless. Um, and it's time for some self-care, and we'll talk about some other ways. So confusion, lack of attention, or difficulty making decisions, physical reactions, easily startled, that's that hyperarousal piece, the somatic piece, stomach ache, so forth, headache, depression, anxiety, and decreased social activity, and diminished self-care. All right. Sense of helplessness, preoccupation, or compulsive re-experiencing. I go home at night and I can't get it off my head and I wake up dreaming about it. I'm in trouble. Attempts to over control in personal or professional situations, or I've got to rescue them. Social support is missing in your life. Maybe you're withdrawing more, isolating, you're feeling tired. You know, those are just some of the signs that can say it's getting to you. Okay. So this is a new model that I've recently found about, because a lot of what I've read and seen over the years that talks about self-care, talks about life-work balance, talks about what do you do to take care of yourself when you're not at work. This model says, well, let's think about what we do while we're at work, which I really like. And I could do a whole presentation on this, but I wanted to introduce you to the concepts a little bit. So the experiential engagement is as much as you can be in the moment and be present with someone, because if you're worrying about how you're going to take care of them and you're not really present, that can wear you out more than if you're really with them as they're expressing what's going on. That's a quick and incomplete response to that one. But anyway, conscious narrative is kind of really connecting to, I'm doing this for a reason. I'm doing this because I'm called to do it. I'm doing this because I care about these people, and my value in life is to help people. And so if I can stay connected to the bigger picture of this is my value, this is my ethic, that helps me get a little better perspective, maybe in the moment, or, caring about people is sometimes easy and sometimes hard, but caring about people is what I want to do. So that's what I'm going to do. Okay. Parasympathetic recovery is some of the skills that we talked about. Maybe I need to breathe. Maybe I need to get up and walk. Maybe I need to get more present. Maybe I need to connect with someone. It's nice sometimes to be able to walk down the hall and talk to a colleague and say, man, this one's getting to me, or, I'm having a hard time here. Decreasing rumination. And that's just using some skills, mostly cognitive skills, to help you kind of get out of the worry cycle. I like to think about an imaginal container that is okay, I'm putting this in this box. It's in the middle of the night. I can't do anything. Putting that worry in this box, putting the lid on the box, putting the lock on the box, putting the box up on the shelf, or I'm shipping this box to God and giving it to him so that I don't spend the night worrying or ruminating about something. And reducing emotional labor is, again, if I'm working with someone and I feel stuck with them, that makes me tired. If I'm able to be really present with someone and it feels like a genuine connection in the moment, that doesn't wear me out. Okay. That can actually energize me. Right.
15.
Okay. Yeah. All right. Next slide. Is balance awareness with connection. Next slide. This is an MRI of a mother and a child. And I don't know how well you can see it, but the mom is kissing the baby. This is an fMRI again. And where the mom's brain lights up, the baby's brain lights up. It's an MRI of love. All right. So beyond this, I've just listed some practical skills for you. Slip on over until we get to the R-Connect slide.
Chief Baker, you might consider kissing your officers on the
There we go.
head.
There's the answer. That's the number for a program at UAMS called R-Connect.
We'll connect you with proper attorneys also.
Next slide. While you're kissing your officers, you might want to consider making a call to R-Connect. Can we move to the next slide? Yeah. So it's a comprehensive behavioral health treatment referral program. So they'll do short-term care and help find a provider for Arkansas. And
Okay,
all
so
of
this
them.
is a service that UAMS is offering
Correct.
now. Okay.
Correct. And on the slide before that was their phone number.
Okay,
And on the slide after.
and it's statewide.
statewide. Mhm.
And services now, post-pandemic, is it easier? Is there any telehealth connection to telehealth in case someone's
Mhm.
kind of in the sticks or can't
Mhm.
travel?
Mhm.
Okay.
Mhm. 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 So it's 24/7. Televideo is possible. And they will help connect you to resources. Okay. And that will get you more information. And we're done.
Good. Any questions, y'all? This was Dr. Everett. Thank you so much.
You are so welcome.
Any questions, y'all, for the doc or anyone else that you happen to see and know on this Zoom stream here? And you don't have to type it in chat. You can just come off of mute if you've got a question.
We can call this Stump the Expert.
We good? Okay. Well, thank you all for joining us. And Dr. Everett, thank you so much
You
for
are so
taking your time
welcome.
out and sharing your wisdom with us.
Sure.
We are going to share the slide deck, and there was something else we were going to share. Numbers, so hotline numbers to call. We'll share that with this group, and we'll do that via email afterwards. I do thank you all very much for what you do, and I will just say that we're starting to look at data in different ways on the work that we are doing together, and y'all, it's having, so in the social science world, a 10% change is considered significant. It's a needle move. And so in Fort Smith, over the past couple of years, the work that they were doing together, one of the outcomes was that they doubled the reunification rate for parents whose children were in foster care. It went from 42 to 85%. We're now tracking that in other communities, and we're tracking it in Sebastian right now. And we haven't been operating in these other communities as long, but it is significant. The reunification rates are way more than 10% impact. And this is because we're partnering with law enforcement and with judges and with sheriffs, so the jail, and licensed counselors and substance abuse providers and helpers in the community and hospitals. And we're able to coordinate our response and work in the way that we all know that it should happen, and the outcomes are much better. And so the win for us is the working together, is making plans, coming up with problems at grassroots, implementing them, learning from outside of our communities and adapting it to inside of our communities. And what we're finding is when we're doing that together, the outcomes are very, very significant. So thanks for what you do. I consider it quite an honor to be able to do this with you all. And I thank you again one more time for coming in and sharing.
Thank you for having me. I'm
'cause-
very appreciative of the work that you do.
Thanks, Doc. And thanks you all.
Y'all.